Recording stopped.
Sir, you are muted, sir.
In progress.
There was some problem with connect. It is now visible.
It's visible, sir. It's visible.
So we got some connectivity problem. So this is the examination. What the examiner wants, it must be, the thesis must be broadly consistent, and every examiner want to pass a thesis. But it is up to the scholar how we write. The very few examiners are there who do reject your thesis. And generally, as I told, introduction part and materials part, material methods part, a evaluator reads it very vividly, and he or she, you will judge your thesis according that way. And as we submit the thesis in the library. It may be in protocol or in any Ayurvedic college, we submit that. But the readers are not always the Ayurvedic persons. So the readers may be medical officers. The readers are of different categories. So we have to know that we have to satisfy those readers, those who don't know Ayurveda, those who know something. So for them also, our language, our presentation style must be that in that way. And when there is some typography, we have always a thesis must be always clear from typographical error. When in the evaluation report, dear students, there is a column by each and every university that grammatical, there is no major grammatical errors or typographical errors in the thesis. If that has to be thesis, that part is also be considered. And the thesis, favor a thesis, engage with the literature. I will come to the next slide. How you will engage the examiner with your literature review. And favor the thesis, convincing approach, examiner thesis, engage with the findings. You have to engage the examiner in terms of literature review, in terms of convincing approach, in terms of your findings. So in that, and every examiner wants that your thesis must be published. And to publish a thesis in a good research journal, a good index research journal, the quality of your, it may be a negative result or you may get a no result at all, but if you are presenting your thesis matter in a positive way, in a very scientific way, thesis, there are so many journals, there are 2 to 3 journals I know where I have also published that negative results. Don't think that if you are getting a negative result, our article won't be published. But there are journals which published your articles in a negative result also. And we have to see the feedback also. So, dear friends, how you will engage the examiner with your review of literature or literature at each point of the thesis. At each part of the thesis, you have to engage the examiner with your critical scientific thinking and updated available literatures. It may be in the part of introduction, in the part of literature review, everywhere you will engage you will force the examiner, force the reader to think that yes, the scholar is updated, the scholar is critical about the literature, present status of his with the concept what he or she is going to do the research, what kind of he or she has carried out the research. The thesis, favor a thesis, efforts also here you have to inside the literature. I will come next slide. The updated methodologies which you have adopted for your research work. It may be clinical, it may be experimental, it may be other activities or a review of literature also. In the activities and literature review, and you have updated methods, and the methods each nationally or internationally accepted one. You don't write the procedures detail. You don't need to write that. The scholar, the examiner can adapt that part also. And the result part also, and the discussion is the most important part, where you can engage the examiner and or the reader with your critical thinking by citing research journals. So in this way, you can engage review of literature, plays a major role in the thesis writing. And because with the format, nowadays the science, the technology, how to use the technology while writing a thesis, the students in a lecture are available. Many things we only use a very few things from the computer, and we all does the things while writing a thesis to manual form. Manually we are, and there are so many informations available on the net on how to write, how to put. We are only using reference. Even student does not use the referencing format of MS Word. They use it manually. But there are many skills. You can utilize those skills. Some basic format. Then how to spelling checkers. Then tables and figures. How you can use that one. And particularly use styles to make your headings, subheadings. Because while you prepare, while you discuss with your guide, the students, there you can put the chapter in the chapter division itself. You will find fix the font size, the font format, what will be the heading, what will be the subheadings there, and all this bibliography, what should be there, everything is well designed in a MS Word format. If you go through, if you are trained, at least your student, and I request those who are experts, those are teachers, they should train their students at least 3-5 times in their first year or second year, third year, how to use this technology to write the thesis in a proper format. They will be master if they train themselves in that way also. So manual formatting requires the font size. All these are, because time is very short, I have already crossed my limit time. I'm not going to. So these things are there. How to do this part. These are the Microsoft Word format what I use to teach my students. They use this format, MD and PhD students. This size, they must be trained in this way, how to write the thesis in that part. So format of, now we have main headings, we have subheadings also in thesis writing. All these things should be taken into considerations, and the major part of the format, we have 3 formats. While writing a thesis, we have 3 formats, that is front matter. While every university also have their own instructions, what should be the format, front format, then how should be the body format. What should be the title page, abstract, table content, list of figures, list of nomenclature. It must be clear in the front format, and in the body format, the introduction, theory, materials, methods, result, discussion, conclusion. How to fit these things are there. And lastly, the end matter, that's your acknowledgement, appendix, and bibliography, and particularly all these things. So a thesis writing format is somewhat different, and you must know, a scholar must know all these things in a better way. And different components of a good thesis, these are the points I want to discuss, but it is so a good thesis must be these are the components where you can students can go through, and for a competition, when you are putting the thesis for the competition, you must follow this so that you are shortlisted. As the organizing secretary Vijayanath was telling that they got 92 theses, 100 theses, and near about 100 theses, and out of them only 11. And so students, if you perform, these are the points which the evaluator and the panel of give my regards to the panel of examiners, 10 or 11, 7 or 10 examiners, those who have evaluated. It's a very critical job. But the students, if you follow these times, then your thesis must be. So citing references is also one of the major part there. So with this, I again thank the organizer for giving me the opportunity, and for I also take some few more minutes out of my scheduled minutes. So I apologize for that. And thanks, Jadavan sir, thanks, Uday Kumar ji, Manoj ji, and Bijanarji for giving, and all the audience for their patient for listening. Thank you. Thank you all.
Thank you, sir. For the felicitation note, we welcome Dr. Sadat Dinkar, General Secretary, AMAI.
Thank you, Doctor. Respected Chief Guest, Dr. Ravi Narayana Acharya, Dr. V.G. Udayamar, President, AMAI Research Foundation, Dr. Vijayanath, Dr. C.V. Jayadevan Sir, VPSP Ayurveda College Principal, Dr. Manoj Kalur, Chairman Organizing Committee, and Dr. Vinod Kumar and Dr. Arun PB, the Organizing Committee, and the Honorable Judges, the participants, and other senior doctors and dear friends. First of all, I would like to appreciate AMAI Research Foundation for organizing this program successfully. It's a great pleasure to conduct this thesis presentation competition under the name of Dr. Agnivesh Sir, a legend with extraordinary wisdom. His knowledge was not limited to the field of Ayurveda. He was the opinion that in Ayurveda, there is a need of refinement, and he had always spoken about the importance of research in Ayurveda. He was the proponent of progressive ideas. He was the founder, chief editor of APTA, the monthly journal of Ayurveda Medical Association of India. The name APTA was given by him. The word APTA means Ayurveda Progressive Thinkers Association. The name itself is an example of his foresight. It's a prime responsibility of Ayurveda fraternity to present evidence-based Ayurveda before the scientific community of the whole world. We are really lucky to have Dr. Ravi Narayana Acharya, the Director General of CCRS, for the inauguration of the function. His speech was very informative, and I think the CCRS has conducted a lot of research in connection with the COVID during the past 2 years. We, the Ayurveda community, expect a lot more from you and CCRS. We extend all kind of support and cooperation for you and your organization, sir. I think the science evolves through a rigorous and continuous research. Ayurveda, the ancient Indian system of healthcare, needs to be validated on modern scientific research methodology without compromising its basic tenets and philosophy. A full system validation would be the right approach in this direction. The objective of AMAI Research Foundation is to promote research and Ayurveda and publish them. The knowledge of Ayurveda should be presented before the public with the backing of such scientific studies. The herbs making a comeback, and there is a herbal renaissance taking place all over the world. According to the World Health Organization, herbs are used by 75% of world population for the basic healthcare. The possibilities of Ayurveda now exposed to the world. By realizing the significance of global acceptance of Ayurveda, WHO has decided to launch the International Research Center of Alternative Medicine in India. The whole world is looking forward to Ayurveda as a simple, safe, side effect-free treatment system. We need to take the advantage of this opportunity. And now I wish all the very best to all the participants. And once again, I appreciate all the organizing committee members who had worked hard for the success of this program. Thank you.
Thank you, sir. Next, we invite Dr. C.V. Jayadevan, Principal, BPSV Ayurveda College, for the felicitation note.
Sir, you are not audible, sir.
I think there's I'll speak later.
Okay, sir. Okay.
I wish all the best. I wish I really I think I'm audible.
Sir, can you put off the video? I think then it will be more audible.
Is it okay now?
Okay, sir. Please.
Respected Chief Guest, and all the senior leaders of the AMAI and all the finalists and the members of the jury. I take this opportunity to congratulate all the finalists. It's a very prestigious event, and it's the third edition of the event, and the background is already been explained. And I'm really proud to host this program. I'm really proud to host this program, especially this program with Dave was a universal person. I don't want to leave it only to the particular. He was a universal phenomenon. He was a universal intellectual person of Ayurveda. He's a great, he was a omnipresent great. I remember him at this moment, and all the members of the judge very close to them, very close to Australia, very close to them, and also close to Proverbial. And it's a wonderful event. And this program every year is getting more and more popular and become very prestigious. I'm very proud to be a part of this. Proverbial is very proud to be a part of this program. And I take this opportunity to congratulate Dr. Analogistic for becoming the Director General of Recruitment. You have seen all the students who have studied this go through his biodata. Slowly and steadily, because of hard work, he has come to the national platform. He is really a role model. He is very serious about research. We are expecting a lot from him, especially Kerala is expecting a lot from him because Kerala is an organization leading the research in all over India. And we have only 2 centers in Kerala. One is Chirudurgi and another is Pujapura. So we need more centers and more intensive research work in Kerala. We seek his support. AMAI is always ready to cooperate with all the national activities at the national level of CCRIs. This was once again congratulate Dr. Acharya for becoming the CCR, teacher of CCRIs, and also congratulate all the finalists. Thank you.
Thank you, sir. Organizing Secretary Dr. Arun P.B. will now be delivering the vote of thanks. We welcome you, sir.
Thank you, Doctor. Thank you, Doctor. Respected dignitaries on and off the stage. Now the inaugural session is over, and we are eagerly waiting for the presentation session. On behalf of organizing committee, I'm glad to be standing here to express my vote of thanks. First of all, our special thanks to Acharya sir for accepting our letter, invitation letter, and for being here, and also for his thoughtful and guiding presentation. Man who is always inspires us, guide us, and providing all the necessities for this program. Thank you, sir. And I extend my heartfelt gratitude to Dr. Sadat Dinagar, General Secretary, Ayurveda Medical Association of India, for being here and his kind words and wishes. For being official, I express my thanks to Dr. Vijay Udayagumar, Chairman, AMAI Research Foundation, who presided this function, and Dr. Vijayanath, Secretary, AMAI Research Foundation, who presented a brief report of this program, and also Dr. Manoj Kalu, Chairman of the Organizing Committee, who delivered the welcome speech. We are grateful and we express our thanks for the 4 eminent judging panel for being here to shape and guide our delegates, and also those 21 judging panel members who have done the preliminary screening of the delegates. And I'm giving a wide round of applause and wishes to all participants who are here since from the preliminary session, all participants. And finally, I express my sincere thanks to the entire team who are behind this program and also assembled here, including teaching faculties, PG students, house surgeons, students union members, under the coordination of MD Vinod sir. Their continuous efforts made this event a grand success. Finally, I express thanks to all academicians, teachers, doctors, and my colleagues, students. All are being here.
Thank you, sir. Now, we start off with the most eventful lineup of the day, the thesis presentation competition. Let me start by introducing the esteemed panel of judges we have with us today.
Dr. Suhas Kumar Shetty holds an MD and PhD in Ayurveda. He is an Ayurvedic practitioner, academician, and researcher specialized in mental health. He is a reputed technical expert in various national and international policy documents and consultation meetings like WHO, CCIM, CCRAS, etc. Currently, he is the principal and medical director at KLE Academy of Higher Education and Research, Sri BMK Ayurveda Mahavidyalaya, Belgavi. It is an honor to have you with us, sir.
Dr. Supriya Balarao holds MD and PhD in Ayurveda and PG Diploma in Bioethics. She is the chairperson of Ethics Committee, Cipla Palliative Care and Training Center, KLE BMK Ayurveda Mahavidyalaya, Belgavi. She currently works as Associate Professor in the Obesity Research Lab at Interactive Research School for Health Affairs, Irsha, Bharati Vidyapeeth, Pune. It's a pleasure to have you here, ma'am.
Thank you.
Dr. Alathur Narayanan Nambi received his BMS degree from Mysore University, Karnataka, and his MD from Rajiv Gandhi University of Health Sciences, Bangalore. He is popular as international teaching schools as faculty member of Ayurvedic Point, Italy, Equal International Australia, and Veda Education in Russia. He is presently the principal and chief physician of Ashtangam Ayurveda Chikitsalayam and Vidyapeeth, Palakkad. We welcome you, sir.
Thank you.
Dr. Arati BS pursued her BAMS degree from Government College of Indian Medicine, Mysore, and MD from Government Ayurveda College, Trivandrum. She took diploma in German from University of Kerala. She has served as a guide for a research titled Role of Pharmacist in Herbal Therapy conducted by students of Cheran College of Pharmacy, Coimbatore. She is an academician and administrator and has served at Ayurveda College, Coimbatore and Chandagiri Ayurveda College. She mainly focuses on lifestyle disorders.
Now we are moving on to the PG thesis presentation competition. Rules and regulations of the program are as follows. The time of presentation shall be 10 minutes. There will be interaction with the jury for not more than 15 minutes. There will be a warning bell at the end of the 9th minute. Please stick on to the time provided. The judges can intervene at any time of the presentation. The organizers shall not be responsible for any technical glitches occurred from the side of the candidate. No additional time will be provided for the same. The presentation should include research question, objectives, hypothesis, methodology, observations, discussion, summary, conclusion, limitations and recommendations, and contributions to science and society. The decision of the jury will be final. Dr. Arun PV will now be taking over the session. Sorry, Dr. Arjun M will now be taking over the session.
So let's begin. So let's begin our presentation. And I hope all the judges are ready and all the contestants are ready. We have already mentioned our rules. We have allotted 10 minutes for the presentation, total 10 minutes for the presentation. There will be a warning bell at the end of 9 minutes. Then the participant has to conclude the presentation within 1 minute. Then the presentation will be followed by the discussion. The discussion will be initiated by the judges, and the discussion will be for 15 minutes, 15 minutes. So I request all of you to stick on to time. And also 4 minutes are allotted for each judge. There will be a warning bell after 4 minutes. Then the total time for discussion will be 15 minutes. So I request all of you to keep time. So let's begin our presentation. Wish you all the best. And once again, I welcome all the judges to this prestigious event. Dr. Supriya Bhalerao Madam, Dr. Subhash Shetty Sir, Dr. Narayan Nabi Sir, and Dr. Arati Srivals Madam. First of all, I invite code number T22004, Dr. Shahbaz Alam, to present her presentation. Once again, code number T22004, Dr. Shahbaz Alam, please.
Shall I start?
Just please note, this is code number T22004.
Shall I start, sir?
Yes.
Hello.
Please share your screen and start.
Okay. Sir, the screen is visible, sir?
Is visible. Please make it full screen. Can you make it full screen?
Sir, it is full screen, sir.
Because 3 slides are coming together. Okay, now it's okay.
Okay, okay, sir. Shall I start, sir?
Yes.
Okay. Good morning, everyone. Myself, Dr. Shahbaz Alam. I done my PG from Kahashri BMK Ayurveda Mahavidyalaya, Belgavi, under the guidance of Dr. Santosh YM, sir. Now coming to my title of the research, it is Innovative Technique of Sharsutra Application by Double Loop in the Pain Management of Bhagandar during threading or randomized controlled clinical trials. The research question of my thesis is whether innovative technique of Sharsutra application by double loop in the pain management of Bhagandar fistula in nano during threading is effective. Objective of my thesis is first to evaluate the efficacy of innovative technique of Sharsutra application by double loop in the pain management of Bhagandar fistula in nano during threading. Second is to compare the innovative technique of Sharsutra application by double loop over a railroad technique in the pain management of Bhagandar fistula in nano during threading. Now coming to hypothesis, S0 is use of Sharsutra application by new technique in the management of Bhagandar fistula in nano is not effective. S1 is use of Sharsutra application by new technique in the management of Bhagandar is effective. Now coming to my methodology of thesis, plan of study is occur at KLE Ayurveda Hospital and Medical Research Center, The source of the data is patient of OPD and IPD shall be taken from Shalyatantra Department of Kahir Ayurveda Hospital, Belgavi. Study design was randomized control clinical science. Study period is 18 months and total sample size is 13 divided into equal to group. In group A is changing of Shastra application by Shastra by loop, and group B is changing of Apamark Shastra by railroad technique. Randomization was done by online software named as random number generator. Intervention procedure is group A changing with by double loop technique and group B changing Shastra by loop technique. Duration is Shastra changing was done for consecutive session after primary threading. An assessment, the pain was assessed on 2 consecutive thread changing session with a gap of 1 week duration. Now coming to inclusion criteria, the patient of line arrow and the second is patient was selected between the age group of
Problem? Can't hear.
Dr. Shahbaz?
I'm audible, sir.
No, there is a disturbance in between.
Okay, sir.
Don't you have proper
Okay.
connectivity?
Sir, there is problem, sir, here. Network issue is there, sir.
Okay, you continue, please.
Okay, sir. Sir? Hello?
Yes.
Okay, you continue. Please. Yes.
Okay, sir. Now criteria, like inflammatory body, diabetic mellitus, HIV, and pregnancy. Some case of Crohn's disease, ulcerative colitis, malignancy, and tuberculosis. Now coming to standard procedure of my thesis. Purkarm and Prasad both are same in the 2 groups. Purkarm is written informed consent of patient was taken. Part preparation was done and Shastra application instruments are Apamark Shastra as per API standardization. Sponge holding forceps, mosquito forceps, scissor, glove, gauze, pad and surgical tape. Prasad was same in both the group. Clean the iodine solution. Gauze was placed locally, bandaging was done. Now coming to main operative procedure, changing patient was kept in lithotomy position and painting was done with antiseptic solution. Shastra was folded from the center point so that new Shastra inserted in the loop of old Shastra through proper holding. Then the knot of old thread was cut so that it became free from both the sides, and then with the change within a fraction of second without anything. Both these steps are shown in this picture. Now coming to group B, Shastra changing by railroad technique. The patient was kept in lithotomy position and painting was done with antiseptic solution. Change of Shastra was done by railroad technique. New Shastra was applied later to the knot of previous thread. Then artery forceps or mosquito was applied medial to the same knot. Then all thread was cut between the artery forceps and the knot pulling of the artery forceps along with the thread ultimately replaces the old thread by new Shastra in the thread. Cut old Shastra and end of the new will be tied firmly. All steps are shown in this picture. Now, assessment criteria is only pain, which is based on the visual analog skill chart and verbal descriptive skill chart shown in this picture. Now coming to assessment chart, it is patients come to my included in my thesis visited for 2 times. One is after primary heading with check was and VDS during after, and after 14 days we check during and after. Now coming to observation, comparison of group A and group B with VAS score at during and after first visit by Mann-Whitney U test. In group A during Shah-Sutra, changing the mean score of VAS was 3.1 and after Shah-Sutra changing it was 0. In group B during Shah-Sutra changing, the mean score of VAS was 6.7 and the Shah-Sutra changing it was became 1.5. The significant result was observed in between the group, that is P is equal to 0.001. Into next slide is comparison of group A and group B with VAS score during and after second visit by Mann-Whitney U test. In group A during Shah-Sutra changing, the mean score was 2.6 and after Shah-Sutra changing it became 0. In group B during Shah-Sutra changing, the mean score of VAS was 6.6 and after Shah-Sutra changing it was 1.5. That shows that results were observed in between group, that is P is equal to 0.001. Now coming to comparison of group A and group B with the VDS score at during and after first visit by Mann-Whitney U test. In group A during Shah-Sutra changing, the mean score of VDS was 3.4 and after Shah-Sutra changing it became 0. In group B during Shah-Sutra changing, the VDS score was 7.2 and after Shah-Sutra changing it was 1.9. That shows significant result were observed in between group A, that is P is equal to 0.001. In comparison of group A and group B with VDS score at during and after second visit by Mann-Whitney U test. In group A during Shah-Sutra changing, the mean score of VDS was 3.0 and after changing of Shah-Sutra it became 0.6. In group B during Shah-Sutra changing, the mean score of VDS was 6.9 and after Shah-Sutra changing it was 1.1. Significant results were observed in between the group, that is P is equal to 0.001. In group A and group B with score was Wilcoxon match pair test. Within the group, results were assessed by Wilcoxon match pair test, which showed significant result in both group A and group B. No pair observed in group A after Shah-Sutra changing. A comparison of during and after first and second visit in group A and group B with pain VDS scored by Wilcoxon match pair test, which shows within group result were assessed by Wilcoxon match pair test, which shows a significant result in both the group A and B. No pain was observed in group A after Shah-Sutra changing. Now coming to discussion of observation, 53.3% cases were found between the age of 31 to 55 years. Conclude that occurrence of Bhagandar is most prevalent among the middle age group as a result of consumption of apachya ahar and vihar, as well as lack of hygiene of perianal area. Most in gender, most of the patients are males, which shows susceptible to etiological factor of Bhagandar than females. Socioeconomic status. Most of the patients belong to the poverty, below poverty line, middle class and lower middle class. It is indicate that understanding of the disease and its complications. Occupational status, 63% has occupations like sitting due to a long-term sitting, which shows now coming to appetite, 70% has decreased appetite, has a connection to Bhagandar caused by Mandagini.
Excuse me.
Bowel habit. Yes, sir.
It's time. Please conclude.
Okay. Discussion on effect of technique on pain. Significant reduction of pain, that is P is equal to 0.001 was observed in group A when compared to group B. Sarsutra is a multi-phase treatment wherein patients undergo frequent changing and suffer pain and discomfort along with hampered quality of life. Pain in railroad technique is due to multiple knots placed on the Sarsutra while pulling out the old thread causes a tremendous amount of friction or irritation to the healthy granulation tissue in the tract. Due to this, there is hesitancy and non-acceptability of the treatment affecting the treatment. Previous study by Goranga Dutt 2015 et al. Shows that Sarsutra therapy done with the railroad technique as a mild pain, which is 15 patients, moderate pain 6 patients, and severe pain 2 patients among 26 patients. Series of multiple knots during thread changing double loop was an innovative method which shows reduction in pain and irritation, thus making the procedure patient friendly. We conclude the thesis. Innovative double loop Sarsutra thread changing technique is effective in the pain management of Bagandar during threading. Within the group, result of pain parameter assessed by the Cox and Max status found significant in both the group. Between the group, result assessed by Mann-Whitney U test shows significant changes, that is P less than 0.05 in innovative double loop Sarsutra thread changing technique group when compared to railroad technique. And a summary of my thesis is Bagandar is considered as one of the Asthmahavada and it is second most prevalent anorectal disease after Ashas, commonly seen in anorectal surgical practice. Sarsutra become a primary modality for managing Bagandar and it is multi-phase treatment wherein patient is called for the frequent thread changing procedure, and during thread changing patients suffer with pain and discomfort, that is patient decline or discontinuity treatment. To overcome this problem and encourage the patient to continue the treatment, here an effort has been made to innovate the thread changing technique to manage a case of Bagandar which offers less pain and
time is up,
discomfort.
please. Code number 22004. Note that was just number T22004. Dr. Shahbaz Alam. I request Dr. Shahbaz Alam to turn on your video.
Okay, sir.
And for discussion. I request Dr. Priya Bhararao, madam, to initiate the discussion, please.
Hello, am I audible?
Yes, ma'am.
Yes, ma'am.
Before I start discussion on this particular topic, I request organizers that can they make all the other participants on mute mode because there is a lot of background noise.
I request all others to please mute your microphones. And I have a small request to all the contestants that your thesis have been already evaluated by the honorable judges. So you need not explain all those stuff. Please stick on to time. Okay.
Yeah. Coming to your presentation, first of all, congratulations. The work is very nice. But I have few suggestions and few questions also to you. The first suggestion, because this is a thesis competition and we are going to even discuss few flaws in the methodology. So there are few suggestions. In your research, in your hypothesis, you have mentioned that Sharasutra is double loop Sharasutra is effective and double loop Sharasutra is not effective. Actually, this null hypothesis and alternate hypothesis is a statistical term. And when you are doing comparative study, you have to put null hypothesis or you have to state the null hypothesis in a way like innovative double loop technique is not effective, is not more effective than a railroad technique. That should be your null hypothesis. And then it is more effective is your alternate hypothesis. So this is something you should keep in your mind because you are doing a comparative study and you have to state null hypothesis and research alternate hypothesis in a proper way. Second thing I would like to suggest you that when you are appearing for such thesis competitions, you should join from laptop because then now your WhatsApp messages are getting flashed and all. So it doesn't look good for a thesis competition like this. So you should have taken care of arranging one laptop for this particular session, and you should have joined from laptop. These are my sincere suggestions for all the other participants also. If you are joining from your mobile, please try to join from laptop, because that would be a better thing. Now coming to your presentation and your work, I just want to ask you one question, that you have used Man-Whitney test. Can you tell me why Man-Whitney, why not t-test? What was the logic of applying Man-Whitney test or Wilcoxon-Ransom test and not t-test? Hello? Do you know the
Yes,
do you know the answer of this question?
No, ma'am.
Okay, fine. Thank you. Over to Dr. Suhas Kumar Shetty.
Thank you, Dr. Supriya, madam. A very good morning to all of you. Dr. Shahbaz, can you just tell me that you have mentioned about the sample size as 30? You know, how
Yes,
do you
sir.
calculate this? Can you comment on your calculation of sample size?
Sorry, sir.
How did you calculate the sample size as 30, 15 in each group? Am I audible?
Yes, sir.
Yes, sir.
Yeah.
Yes, sir.
My question is, you have mentioned the sample size as 30, 15 in each group. My question is, how did you calculate this sample size? Okay. Have you done any publications related with this work in any of the journals?
Sir, we are going through. We are submitted to JIM, sir.
Okay. Any observation in the types of Bhagandara and the results?
Yes, sir. Most of the cases like to Riju Bhagandara, which is Vatka, sir. Most of the patients, sir.
Okay. You have any observation on the unit cutting time?
No, sir. We are only focused on the pain.
No, any additional observation that you did on that in
No,
healing?
sir.
Okay.
No, sir. Only we are did on pain, sir.
Okay. Okay. Thank you. I think I request Dr. Aarti madam to take it forward.
Namaste, sir. Am I audible?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay. Dr. Shahbaz,
Yes, ma'am.
good that you have tried to find a new technique for the Bhagandara threading change. And I would like to know what all are the care that has been provided to the patient during this technique, apart from the technique as such. That means what type of internal medicines were provided to both the groups?
Okay. But normally we use Triflacoglu and Nimbadivoglu.
Because most of your patients had loss of appetite and most of them had Vibandha. So have you taken care to address those issues?
Yes, yes, ma'am. We give most of the patients Chitrakadivati and Hingvastak Chuna. And for Bhagandra care, we give Nimbadivoglu and one tablet capsule. Ma'am, one Gandak Rasayana and this Jatyadi oil.
Okay, okay. And up to another question, that you have cited one previous work by Gauranga Datta. So
Yes,
which states that out of about 23 patients, about 15 had only mild pain and about 6 had moderate pain, and severe pain was observed only with 2 patients.
Yes,
so you have cited this particular work telling that
Yes,
mild pain was the main trend, and and the very reason for you to choose this topic, because patients used to suffer a lot during the changing the threading. So
Yes,
how do
ma'am.
you substantiate, and what's the reason for you to quote this particular work?
Ma'am, mainly I mentioned in my thesis in introduction, we give we conduct a retrospective study in my college in KLE. Of data of 2 years, we observed that most of the patients are discontinue the treatment during threading. Some patients discontinue the treatment due to pain.
Okay. That observation in your own hospital, that is what made you to choose the topic.
Yes, ma'am.
Okay, fine. Dr. Nambi.
Thank you, madam. And Dr. Shabazz, just now you have mentioned that you have given some oral medications, including you mentioned even Jatyadikrid, etc. And you also stated that there are a lot of people having Mandagni, and maybe you are also given some laxative type of things. But while presenting the whole content, you never mentioned anything. It is related with the thread and thing. So is it not the violation of the content? You see, you are making a scale of pain, and the medicines what you are given, maybe you are not really mentioned the medicines, but now you are told that there are some set of medicine you are given, some Chitragadi Vadi, etc., etc. Then these medicine also will have a great influence on the pain. This also influence have changes in the Bhagandaram. So how do you justify that?
Sir, my thesis only focused on thread changing. While we change the thread after primary threading, we focus on pain by VAS and BDS.
But of course, my question is that, you know, you are one of the major scale you are used is about the pain scale and all. So whenever we give some medicines like Jatyadikar, whenever we use Chitragadi Vadi, is it not will influence the pain? Don't you think that it will not influence the pain?
Maybe, but sir, we just observe the patient during threading. Pain was assessed during threading only, sir.
Okay, did you give any laxative also to the patient?
Sometimes, sir.
Any anuloma medicines?
When they complain constipation, sir.
Okay. Second question is, what made you to ask, already Suhas asked, what is the idea for taking only 15, the size of the sample size into 15?
Sir, it is the minimum size in my college for taking this sample.
Okay, that's fine. That's fine. Okay, good. Right. That's all.
Okay. Just shall I ask one question?
Yeah, please, madam.
Doctor, which is more economical? Is there any change in the cost? Whether a patient can opt for double loop because it is less costly, or what is your overall idea? What is the proposal that out of after all we should know that how patient is benefited, isn't it? Which is more economical?
Ma'am, both are same because the patient purchase a sutra with cost of one only.
Okay.
They charge cost for only one.
Okay.
Just we folded the thread and put we passed it through the track and tied with the loop. Only one thread.
Okay. So as far as the cost is concerned, there are no changes, isn't it? There's no difference. Okay.
No,
okay, fine.
Thank you, ma'am. Thank you, sir. Hope the discussion is over. And thank you, Dr. Shabazz Alam, for your presentation. And judges, please note that was test number T22004, Dr. Shabazz Alam. Thank you. And next I move on to the next presentation. And the next presentation will be by code number T22005. Judges, please note code number T22005, Dr. Swati V. I invite Dr. Swati V to present her thesis. Once again, I am reminding, please stick on to time. Your maximum time is 10 minutes, and please turn on your videos during presentation.
There is some background from this.
Also, I request all of you, all others, to please mute yourself. Dr. Swati, your presentation is visible.
Okay, sir. Shall I make it full screen, sir?
Yes. Dr. Swati, are you ready?
Yes, sir.
Time
Yes.
starts now.
Just a minute, sir. Is that okay, sir?
Yes, yes.
Am I audible?
Yes. Please.
Distinguished,
proceed.
yeah, I'll start. Distinguished judges and all the doctors present in this platform today with me, a very warm good morning to one and all. Myself, Dr. Swati, and I was a PG scholar from Amrita School of Ayurveda, and I did my PG thesis under the guidance of Dr. Delvin T. Robin and Dr. K. Ramadas. My thesis entitled A Randomized Control Trial to Evaluate the Efficacy of Eshtimadughrida Application for Minimizing Radiation-Induced Toxicity in Patients with Oropharyngeal Squamous Cell Carcinoma. This is my research question, whether it is effective in minimizing signs and symptoms of radiation-induced toxicity in patients with oropharyngeal squamous cell carcinoma. These are my objectives: to evaluate the efficacy of Eshtimadughrida in oral mucositis, analgesic requirement for pain control, antibiotic and antifungal requirements, and oral hygiene. My hypothesis and null hypothesis and alternative hypothesis. Moving on to the detailed methodology. This was a randomized controlled clinical trial which was conducted in the Head and Neck Specialty Clinic of Regional Cancer Center, Trivandrum. The duration of the study was for 11 months and the required sample size was 48, 24 in each arm. But due to the COVID pandemic, we were able to recruit only 32 patients. The recruitment was slow, and 17 in the intervention arm and 15 in the control arm. The randomization was done using a computer-generated random table in 1:1 ratio, and all the statutory requirements were satisfied, like institutional review board with reference number this, and human ethical committee, which was independent, and we also registered in the CTRI. These are my inclusion criteria: the patients who undergone radical radiation therapy or chemoradiation for CA oropharynx, and the patients of either gender aged between 30 to 70 years. My exclusion criteria were diabetes mellitus, trismus, and not willing to give an informed consent. Those in the intervention arm were advised to apply Eshtimadughrida approximately 5 grams with their index finger 4 times daily, along with the standard of care, that is soda saline oral mouth rinse. The following consort flow chart shows my recruitment strategy. So after recruiting from the intervention arm, I have allocated 17 patients into the intervention arm and 15 patients to the control arm. And 2 patients from the intervention arm were lost to follow-up due to social reason, and 1 passed away due to a head injury. And another 15 patients in the control arm, and 1 patient was lost to follow-up due to electrolyte imbalance and hospitalization. So after getting an informed consent, which was duly signed by the patients, all of the patients were screened for baseline CBC, serum creatinine, FBS, and lipid profile. The randomization was done, 17 into the intervention arm and 15 into the control arm. They were evaluated for baseline by a blinded assessor who was a radiation oncologist, and oral hygiene assessed by a Dandal surgeon who was also blinded. And they were evaluated after 2 weeks and 4 weeks by the blinded assessor, and the changes were noted in the evaluation sheet. So these were my assessment criteria. The mucositis was evaluated using the RTOG scale. The pain intensity, serostomy, alteration of taste were captured using the VAS score. Analgesic usage using the WHO stepladder analgesic requirement scale. Antibiotic and antifungal requirements were captured, and their oral hygiene using the simplified oral hygiene index. This was regarding the preparation of the Eshtimadu, and a preclinical publication was also done. The statistical analysis, initially descriptive statistics was obtained. Friedman's test was used for repeated measures for all the scales, and later Wilcoxon signed rank test for pairwise comparison of the various scores at different time points. These are my baseline characteristic observation. We have to know that the baseline characteristics, like the socio-demographic, patient-related characteristics, the disease-related characteristics, the therapy, cancer-directed treatment, and the baseline toxicities were comparable. Moving on to my result. This alluvial diagram, it shows a pictorial representation regarding the change in the intensity of mucositis at different point of time. So here we can see that initially in the intervention arm, there were 14 patients who were having grade 3 mucositis, 82.3 compared to 11 patients, 73.3% in the control arm. And after 4 weeks or 28 days of intervention, there were only 12 patients, 70.5% in the intervention arm compared to 8 patients, 53.3 in the control arm. This alluvial diagram again shows the regression in grade 3 and grade 2 mucositis on day 28 in both intervention as well as in the control arm. The next parameter was change in analgesic requirement, and during the end of the radiation therapy or during my baseline, there were 11 patients, 64.7% in the intervention arm who were on morphine or opioid derivatives, step 3 analgesic, and compared to 7 patients, 46.6% in the control arm. And after 28 days of intervention, there were only 3 patients who used a step 3 analgesic compared to 5%, 33.3% in the control arm. And moving on to the antibiotic requirement, none of the patients in the intervention arm required antibiotics when in comparison with 2 patients in the control arm who required antibiotics during the course of the study. And regarding antifungal usage, 7 patients in the control arm used antifungal therapy during the course of the study compared to 4 patients in the control arm. And this was the oral hygiene, which was assessed after 4 weeks of intervention. At the baseline, both like in intervention and control arm, the oral hygiene of the patients were good. And there were 14 patients with good oral hygiene in the intervention arm and 13 in the control arm. And after 28 days of intervention, then none of the patients in the intervention arm degraded to poor or fair oral hygiene compared to 4 patients who degraded to fair oral hygiene in the control arm. So the percentage was 13 patients, 76.4% in the intervention arm compared to 8 patients, 53.3 in the control arm. Moving on to my discussion, the regression of mucositis, it was better in the intervention arm, though not statistically significant. And Yashtimadughrida, it was indicated in Sadhikshadavrana having Madhurarasa and Shitavirya and Madhuravipaka. It pacified the aggravated Pitta and Vada dosha in the Kaphasthana buccal cavity as a result of the radiation therapy and chemoradiation. The Vrana Shodhana and Ropana action might have facilitated the regression of mucositis. And as per literature and various studies, systemic application of Yashtimadughrida was found to be effective owing to its anti-inflammatory, wound healing, and skin regeneration effect. The intensity of analgesic usage, it was better in the intervention arm. The analgesic effect, varies a previous study in a different setting in anal fissure. It explains the possible effect of active compounds like isolicritigenin present in Yashtimadhu inhibiting the COX pain pathway. And none of the patients in the intervention arm required antibiotics because previous experimental studies on Yashtimadhu extract shows potential antibacterial effect against multi-drug resistant bacterial strain. A polyherbal oral mouthwash having Yashtimadhu as an ingredient had shown significant result in maintaining good oral hygiene in patients undergoing radical radiation therapy for oral cancer. On to my summary, the randomization procedure ensured minimal selection and allocation bias. Both arms of the study were well balanced in terms of the socio-demographic habits, disease treatment characteristics, and toxicity profile. The impact of the intervention, it was evaluated by a clinician unaware of the randomization procedure such that the evaluation was unbiased and the measurement error was negligible. This study was conducted in a totally challenging environment during the peak time of the COVID pandemic, and hence the recruitment was slow, it was tardy, and the visits were compromised. And even though after all these challenges, we were able to recruit 32 patients and could ensure good patient compliance and no toxicities were reported. Even though not statistically significant, Yashtimadughrida was effective in healing of oral mucositis, better pain management, minimizing antibiotic and antifungal usage. This is my conclusion. A topical application of Yashtimadughrida is effective in radiation-induced toxicity. In radiation-induced toxicities with oropharyngeal cancer and is feasible to integrate it to modern medicine. These are my limitations and recommendations. The key limitation of the study was the small sample size, which has not yielded a statistically significant power to definitely compare both the arms. And further studies with larger sample size in each arm is recommended. And further studies with systemic administration of Eshtimadugrida is recommended, and the effect of Eshtimadugrida is specifically indicated in Sadikshada Vrana, and it can be studied during the course of the radiation therapy. And use of Eshtimadugrida can be extrapolated to patients undergoing radiation therapy for CA oral cavity and CA
Last
cervix.
1 minute.
Yes, and I would like to take this opportunity to thank all these people who were involved in my study, without which the study would have been incomplete, and my heartfelt gratitude from the bottom of my heart to my guide, co-guide, and my patients and everybody who were with me throughout this journey to make this study success. Thank you one and all for your patient listening. Thank you.
Thank you, Dr. Swati B. Judges, please note that was code number T22005. And we shall quickly move on to the discussion part. I invite Dr. Suhas Kumar Shetty, sir, to start the discussion.
Good morning, Dr. Swati.
Morning,
Can you just
sir.
comment on why did you select the Friedman test for the assessment and the statistical analysis?
It was a non-parametric test, and I was having two groups, and that was the reason why I have selected this test.
Oh, the Friedman doesn't come for the two-group analysis, so
Okay.
it's not the relevant test for the two-group analysis.
Okay, sir. Thank you, sir.
Any publication?
And, Dr. Suhas, Dr. Suhas, if I can add here, she has presented her data in a categorical way. So Friedman doesn't come in picture at all. Because Friedman comes in picture where there are scales, or if she would have recorded the readings as per person, what is a scale score, and then if she would have analyzed, then Friedman or any Mann-Whitney or Wilcoxon would have come into picture. She has presented all the data in a categorical way.
That was the reason I asked this question.
Okay.
Yeah. Any publication that were derived out of this particular findings?
Yes, sir. There is a preclinical publication regarding the physicochemical analysis of the Eshtimadugrida, and it was published in the International Journal of Research in Pharmaceutical Science.
Okay. What is the reference that was used for the Eshtimadugrida? Which reference did you use?
Sir, pardon, sir?
Reference that we used.
Sir, there is reference regarding Eshtimadugrida in Chakradatta, in Vaishajya Ratnavali, and even in Ashtanga Hridaya Uttarasthana in Sadikshana Vrana Prakarana.
It has only Eshtimadu or any other?
No, sir, only Eshtimadu and Grida.
Okay. Thank you. May I request Dr. Supriya Madam to take it forward?
Hello, Dr. Swati.
Namaste,
this was a nice presentation and very much required topic, and I congratulate you because you have completed 30 to almost 2/3 patients of what you have planned for, in spite of being a pandemic period. One of the questions which I wanted to ask you has been already asked by Dr. Suhas about the statistical test. Yes. I want to ask you two questions. First is whether there were any serious adverse events in your study.
Yes, ma'am. I have reported 2 essays in my studies, and 2 of them were unrelated to the studies, and I reported that is 2 patients passed away due to progressive disease, and I have reported it to the Human Ethical Committee within 24 hours, and after analysis, they told this is not related to your studies.
Very good, and I would like to request and suggest all the participants that whenever you are presenting clinical studies, you should mention about the ethics committee permission, that you have taken the ethical committee permission, as I think you have mentioned. Yes, but these serious adverse event things also you should mention properly, that these were the serious adverse events and they have been reported properly. Yes, and my second and last question is, you have presented the data as percentages.
Yes, ma'am. Yes, ma'am. I have presented
many places. I mean, almost all your results are expressed in terms of percentages. Yes, and your sample size is 32. So, yes, is any comment on this? Because if I make it very clear, that percentage is the word itself means percent, that is per 100. And you have only 32. So, presenting the data in terms of percentage can give a pseudo impression.
Okay, ma'am. The thing is that I didn't get any point of value of statistical significance, and I thought showing the change in terms of percentage might give a better impression regarding the efficacy of Grida. That was my sole thing why I have showed it in percentage. and I have calculated the entire I have even evaluated the patients who were lost to follow-up also during the evaluation.
Okay, just a suggestion in future, if you have less than 100 patients or 100 samples, then you can use proportion as your measure rather than percentage.
Thank you, ma'am. That was a great suggestion. Thank you.
Okay, thank you. Over to Dr. Nambi. Hello.
Yeah. Swati.
Namaste, sir.
Namaste. Swati, can you explain a little bit about the intervention of the patient in this case?
Yes, sir. Sir, my baseline was when the patient completes the entire cycle of the radiation therapy, in the intervention arm, along with the standard of care was soda saline mouth rinse. Along with that, I have advised the patient to apply 5 grams, approximately 5 grams of Hishtimadughrida to be taken in their index finger and apply wherever there is pain and mucositis, and for 4 times every day for 28 days. And I used to monitor their progress of application every week. I used to call them and I used to follow up. And one patient, like 2 patients, they felt it a bit difficult due to the palatability while applying it in the throat, but still they managed, and the compliance was good.
Okay, nice. I want to know a little bit about the preparation. You're told that it has been prepared in the Department of Rasashastra and by Shajja Kalpana.
Yes, sir.
So, did you made any standard methodologies to prepare this Hishtimadughrida, since it is not directly, as you mentioned, it may be mentioned like in the Chakradartha and all. Maybe
Yes,
you're taking the Kalkam and Kashayam of the
Yes,
same,
sir.
right?
Sir, from the Sarangadhara Samhita Madhyama Kanda, Sneha Kalpana Adhyaya, preparation of Ghrita Kalpana has been followed for preparing this Hishtimadughrida. And Hishtimadu, approximately 10 kilogram of Hishtimadu, 2 kg for Kalka, and 8 kg for Quadha was used, and 64 liters of water was used for preparing the Quadha, and it was reduced to 32 liters. And later 8 kilogram of Ghrita was added for preparing this, and then approximately 6 kilogram of Hishtimadughrida I have received as an end product.
Okay, let me ask you an out-of-box question. Whether any study similar to that, instead of Hishtimadughrida, whether any study has done or on such cases with the Jatyadik or anything like that? Did you had any such previous works?
No, sir. No, sir. I have searched whether there is Hishtimadughrida itself given internally for protective effect in radiation therapy. There is one study by Das et al. And but in Jatyadighrida given for radiation-induced toxicity, no such studies are there, sir. Because Tutta is there, so internal administration sometimes. That's why Hishtimadu, being a nutraceutical, also it is safe for consumption even if taken internally. Also, the ethical committee people, like they were convinced.
Okay. Okay, good.
Thank you, sir.
Over to Arati, madam.
Hello, Dr. Swati.
Namaste, madam.
Good presentation. I have 1 or 2 questions. My one doubt is that you have started your work on only those patients who have completed the full course of radiation.
Yes, ma'am.
So what was that agreement like? Why couldn't you choose the patients maybe immediately after 1 radiation or 2 radiation? It is as if you were waiting for the full blown off mucositis.
No, ma'am. Truly, ma'am, I had in my mind to use it during the course of the radiation therapy. But while discussing it with my guide, Dr. Ramdas sir, he was telling me that this will not fetch an ethical approval if they were allowed to apply the Hishtimadughrida during the course of radiation therapy, because sometimes the particles of the Ghrida may stick to their oral cavity, and I didn't have any much supportive papers to show that this will not alter the fraction of radiation therapy. So that is why I have taken it like this. After completion of the entire cycles of radiation, this was given. Maybe the previous, like during the course of radiation therapy, might have yielded a better significant result because it is indicated in Sadhyakshada Vrana. So I always had this in my mind, ma'am.
Okay. And the topic is radiation-induced toxicity. And in the discussion, you were silent on xerostomia. could you observe any changes, or what is your comment on xerostomia effect of this Grita application? Hello, am I audible? Hello.
Hello, madam, you are audible.
You are audible.
Yeah, Dr. Swati? I think Dr. Swati is not listening.
Ma'am, there is a technical issue with Dr. Swati. Dr. Swati, are you there? Dr. Swati? This is a network error, I think, ma'am.
Okay, okay. Whether that allotted 15 minutes is over, allotted 15 minutes is over?
No, ma'am. No.
Just wait for a few seconds if she is running.
Ma'am, 1 more minute is left.
Okay, okay. If she is returning, it's fine.
Madam?
Yeah.
Yeah, ma'am, I just lost my internet connectivity on my laptop, ma'am. So
Okay,
right now
okay.
I'm accessing it on my mobile.
Okay, okay, fine. I would like to know what is the outcome of your intervention on xerostomia, because your title is radiation-induced toxicity, but you are altogether silent on the discussion part regarding what happened to xerostomia. Can't hear. Unmute, please unmute.
Ma'am, can you hear me now?
Yeah.
Ma'am, the thing is that I didn't mention xerostomia because it is a late toxicity, and there was there was no effect compared to the control arm in terms of xerostomia, because both the control and intervention arm patients were
okay.
That's why I didn't mention that, and also to cut short the number of slides.
Okay, and can you now go to the slide number 19 or 20?
Yes, ma'am. Now my screen is visible, ma'am?
No.
Yeah, just a minute, ma'am. I'll share it. Okay, ma'am. Is it visible now, ma'am?
Not yet.
Please start the presentation. Yeah.
Okay.
Yeah, slide number 19.
Yes, ma'am. Just a minute, ma'am. Yes, ma'am. Yes, ma'am.
Okay, what is that first sentence mean? Intensity of analgesic usage was better in the intervention arm.
Yes, ma'am, because the patient's intensity of analgesic were...
Intensity of analgesic usage was better in the intervention arm.
Yes, ma'am, because they in the intervention arm, the patients in the intervention arm, the patients in the intervention arm, they were having a less analgesic usage. That is, am I audible, ma'am?
Okay. You are audible. My doubt is that whether you have used this sentence properly or not. Intensity of analgesic usage was better in the intervention arm.
I meant actually intensity of analgesic arm was less in the intervention arm compared, like higher grades of analgesic usage was less in the intervention arm compared to those in the control arm.
Okay. So please be careful.
Actually,
yeah,
ma'am. Thank you, ma'am. Thank you.
Okay.
Thank you, ma'am. Thank you, judges.
Thank you.
That was code number T22005, Dr. Swati B. And quickly we move on to the next presentation. I invite code number T22008, Dr. Ashwati Y. Once again, I invite Code number T22008. Dr. Ashwati YS.
Sir, is my screen visible, sir?
Yes, Dr. Ashwati.
Am I
Are you
audible?
ready? Are you ready?
Just a
On to
minute,
time.
sir. Just a minute, sir. Am I audible?
Yes, doctor.
Okay. Good morning, dear dignitaries and dear researchers. Myself, Ashwati YS from Amrita School of Ayurveda, under the guidance of Professor Anandram Sharma, would like to present our topic, the effect of Niruhavasti medicated enema on Prevotella species of gut microbiota in rheumatoid arthritis patients. Research question: does Niruhavasti has influence over gut microbiota, limiting to Prevotella species in RA? Objectives: to assess the effect of Niruhavasti therapy on Prevotella copri and Prevotella histicola of gut microbiota in rheumatoid arthritis patients, and to understand the effect of Niruhavasti therapy in rheumatoid arthritis when assessed with subjective and objective parameters. Research hypothesis: null hypothesis. Niruhavasti therapy does not have influence over gut microbiota, limiting to Prevotella species in RA, and alternate. Niruhavasti therapy has influence over gut microbiota, limiting to Prevotella species in RA. Methodology: the sources of data: 5 patients were properly screened from 22 patients from Amrita School of Ayurveda, and the trial was registered under CTRI and obtained ethical clearance, and it was funded by CCIH Pune, and gene expression analysis was done at Omixgen Life Sciences Private Limited. A total of 5 patients were selected from proper screening, after proper screening from 22 patients based on ACR or musculoskeletal examination. And when ACPA was detected in the 5 patients, these 5 patients were selected and their fecal sample were analyzed for the presence of Prevotella copri and Histicola. And since we found their presence, 5 patients were included for the study after an informed consent. A course of Sharavasti, 8 days of Sharavasti was administered as per the standard operative procedure. And on the 9th day, again, fecal sample analysis was done. And fecal sample analysis was done after follow-up, that is on the 25th day after Parihara Kala. Then the quantification of before treatment sample, after treatment and after follow-up was compared. The strongest of inclusion criteria was the patients who fulfill ACA criteria and those who were identified with the presence of Prevotella copri and Histicola from their fecal samples before treatment. These are the contents of Sharavasti and Sharavasti Mishrana were done according to the standard operative procedure. Moving on to the identification and quantification of Prevotella copri and Histicola, fecal sample collection was done as per the protocol. Figure number 2 shows how we collected, and extraction and preparation of genomic DNA from isolates using DNA stool mini kit, and amplification of 16S ribosomal DNA of isolates using specific primers by polymerase chain reaction using Rotogene Q and Cybergreen, and then the quantification of the 3 experimental values were compared. These are the melt curves obtained for both the species, Prevotella copri and Histicola, which ensures a single amplicon amplification, and amplification plot of both the species in which cycle a detectable amount of DNA was present. Now moving on to the data analysis and interpretation of recruited patient, as the patient sample was very less, and in order to give importance to each and every parameters of all the patients, as directed by CCIH Pune, we have represented all the data using heat maps, charts, graphs, correlational statistics, and proximity metrics. So here the subjective parameters are given. For example, each value in the patient number 4, each value of Angamarda before treatment was taken 6 times, and its average is noted here. So the total average of all the patients of Angamarda before treatment is 3, after treatment is 1.4, and after follow-up is 0.4. These are represented in the form of heat maps. From the color gradient itself, the improvement can be easily identified. Similarly, Aruji, Trishna, all the Amavata Lakshana has been represented using heat maps. Similarly, the scoring criteria like visual analog scale, ACR joint involvement, ACR criteria, clinical disease activity index, total joint count, swollen joint count, physician global activity, patient global activity, patient activity scale, disease activity scale 28, and the investigations like CRP, ESR, rheumatoid factor, and ACPA also. So before going on to the core part, which is the gene expression analysis, we did a next generation sequencing or a metagenomic sequencing of V3, V4 of 16S ribosomal DNA from the samples of an RI patient and a control as a preliminary step to identify the presence of Prevotella. And not just that, in order to identify if there is a variant, we did next generation sequencing. And to synthesize specific primers also, we did NGS. So to our surprise, this was it was interestingly, we found that in the control, the Prevotella copri was 42.2%, whereas in patient, it was only 0.1%. So this led to the confusion that whether the reference data applicable to us was applicable to the Indian population or not, who follow a non-Westernized lifestyle and who take a fiber-rich diet. So therefore, we went for gene expression analysis of 10 healthy volunteers, from which we could find out that 80% of the control samples presented with high abundance of both the species, Proverbial copri and Histicola. Now, moving on to the gene expression analysis of Proverbial copri, it was compared, all the 5 patients were compared with the 5 controls of same age as well as similar lifestyle and diet pattern, and it was compared with the 3 experimental values of each of the patient. For example, in the first patient, P4, before treatment it was 0.14 nanogram, and after follow-up, after treatment it has raised to 1.3 into 10 raised to 15 after treatment nanogram, and after follow-up it was 6.3 into 10 raised to 14. Even though there is a minimal increase, the value of Proverbial copri has been raised in the form of exponential. Similarly, all the other patients' controls have already been in abundance. It has been represented in the form of cross tabulations, the values of control against BT, AT, and AF values. The correlational statistics extrapolated a strong positive correlation in the after follow-up values. The proximity metrics, the BT value, the distance, average distance between the BT and AT was 1.3 into 10 raised to 15, and after follow-up it is 7.6 into 10 raised to 14. Now, moving on to the gene expression analysis of Proverbial Histicola, all these were compared with the controls of similar age, same age as well as similar lifestyle and diet. Already the control were of high abundance, even though it has not come up to the high exponential value like that of the Proverbial copri. When coming to the example of P19, patient number 19, last patient, from 0.13 nanogram, it has raised to 2648 nanogram after follow-up, which was the highest of all the values. Not even a control has come up to such a greater value. It has also been expressed in the form of cross tabulation and heat maps. The values of controls were quoted against BT, AT, and AF values. The correlation statistics here also extrapolated a strong positive correlation in the AF values. And the proximity matrix is 26.116 nanogram between BT and AT, and it is 2648 in BT and AF. These are the average improvement in clinical features, assessment criteria, and investigation. Now, the probable mode of action of Sharavasti, each of the ingredient of Sharavasti has a role in modulating gut microbiota, either by increasing the commensal organism or by decreasing the pathogenic organism. The impact of treatments in the growth of Proverbial copri and Histicola. Numerous studies have established that Proverbial copri is present in early RA patients, which lead to the induction of RA, whereas Proverbial Histicola suppresses RA. Considering this as the base data, gene expression analysis of 3 samples of each patient were done to quantify both the species in 5 RA patients. So it was seen that both the species showed increased after treatment and after follow-up with reduced clinical signs and symptoms of RA. The results obtained were contradictory to the available base data regarding the pathogenic role of Proverbial copri, but it coincides with the studies proven earlier that Proverbial Histicola suppresses RA. So 10 fecal samples from 10 healthy volunteers were taken from Kollam district of Kerala, and they were analyzed considering the differences in Indian lifestyle and diet patterns. So gene expression analysis of all these revealed that 80% of the total control sample presented with high abundance of Proverbial copri as well as Proverbial Histicola. So, Niruhavasti, specifically Sharavasti, has effect over Proverbial copri and Proverbial Histicola of gut microbiota in rheumatoid arthritis patients, as well as in improving clinical signs and symptoms of RA after treatment as well as after follow-up also. Abundance of Proverbial copri after follow-up along with reduced clinical signs and symptoms of RA in 5 patients of Kollam district in Kerala is contradictory to the studies proving the pathogenic role of Proverbial copri in RA. Not only that, Proverbial copri is one of the dominant bacterial species of Indian gut microbiota in healthy volunteers from Kollam district of Kerala, contradicting its pathogenicity. And the pathogenic layer of Proverbial copri associated with RA may have a link with the host genetic factors and environmental factors, especially diet, which was not an objective of our study. And the growth of Proverbial Histicola after follow-up with reduced clinical signs and symptoms has the capability to reduce the disease activity as proven in the previous study. So, thus the alternate hypothesis may be accepted and null hypothesis may be rejected. Contributions to the science being one of the primary studies which proved the role of an Ayurveda intervention, especially in Niruhavasti, in modulating gut microbiota. This can be a torchlight in conducting further studies in the area of human gut microbiota and Ayurveda. Limitation of the study, the sample size was too less to make a strong conclusive statement. The pandemic situation has worsened the accessibility. The focus was given only to 2 bacterial species, and tracing the variants or claims of these of Proverbial copri was not a part of our methodology. Limited trial duration, and there wasn't any strong methodology to find out the mechanistic action of Sharavasti as an emulsion on gut microbiota of RA. So scope of further study, understanding the whole gut microbiota by next generation sequencing. And study population could have been widened, and the clades of Proverbial copri, which has a pathogenic role in development of RA, can be identified. And the mechanistic role of Sharavasti on Protella histicola in suppression of RA, effect of Niruhavasti in Protella copri and Protella histicola of RA in pan-Indian population, modulation of gut microbiota after Ayurveda treatment modalities designed for the management of Amavata can be found out. This is one of the article related which we published in Ayu Journal, therapeutic influence of some dietary articles on gut microbiota in the pathogenesis of rheumatoid arthritis. Thank you.
Thank you, Dr. Ashwati Vyas. Judges, please note that was please note that was code number T22008. So it's time for discussion. I would like to invite Dr. Arati ma'am to initiate the discussion.
Hello.
Hello, ma'am.
Dr. Ashwati.
Ma'am.
It was good in the sense the topic is very relevant and at the same time not it's a subject which was unexplored so far as my knowledge goes. My question is that why the title is Niruhavasti when you have given only Ksharavasti. Of course, Ksharavasti is a type of Niruhavasti, but what is the justification?
Ma'am, by Ksharavasti itself, if we are getting a relevant data from Ksharavasti, it means that it is Niruhavasti. That's why we meant it as Niruhavasti.
But Niruhavasti is such a wide this thing that there are a lot of variations, and but it's you have tried only on Ksharavasti, isn't it?